So I'm going to be talking about premium IOLs in post-keratoplasty patients, what to consider and what to expect. Now, I have no financial interests. Talking about premium IOLs, these are lenses that are used in cataract surgery that provides more than just the basic vision correction provided by the monofocal lenses, and these include the multifocality, stigmatic correction, and extended depth of focus, reducing the reliance on glasses post-cataract surgery. Now, essential investigations that we need to do before cataract surgery for post-keratoplasty patients, and to be honest, these are my investigations to go in all my cataract patients. Subjective refraction to assess the best corrected visual acuity, especially if the patient doesn't have really significant cataract. So in this case, I can assess what's the best corrected visual acuity I can achieve. Auto case from the auto refractive keratometer to assess the keratometry value as well as the axis of the astigmatism, corneal topography and tomography, biometry, and OCT macular disc and anterior segment OCT in some cases, as well as specular microscopy to see the endothelial cell count. So in order to deal with such cases with post-keratoplasty patients and do cataract, the surgeon should be able to deal with the corneal surface adjustment and high astigmatic management through the femtolaser arcuate keratotomies, which I call relaxing incisions. Also, endothelial keratoplasty, especially DMEK, as well as skills in phacoemulsification and IOL management. So you should be able to work at the surface of the cornea, at the inner part of the cornea, as well as the lens. Now, when should we consider the cataract surgery and what kind of premium lenses to choose with the grafts? Now, whenever we talk about corneal grafts, if we are talking about DMEK, endothelial keratoplasty, I always go for combined surgery. But if we are talking about PKP or DALK, I go for the sequential versus the combined, mostly the sequential. I'm going to explain it now. Let's talk about this case, for example, which I call DMEK triple, DMEK with phacoemulsification and IOL implantation. Due to the high prevalence of cataract after DMEK in patients who are in need for endothelial keratoplasty, usually they develop cataract in the coming 2 years. To avoid stressing the already grafted endothelium, so I like to do a combined surgery with the phaco being done before implanting the DMEK and inserting the graft. My way to go IOL in this case would be a hydrophobic lens, and I would go for a monofocal plus, which is the enhanced monofocal, versus EDOF lenses with targeted refraction of minus 0.75. Of course, the target refraction depends on the amount of the edema for the patient. The more the edema, I target more minus because the cornea will detrogest and it will cause some hyperopic shift. If we look at this case, for example, I don't know if the pointer is not probably, if it's working, yes. You can see that the pachymetry here is about 800 plus microns. This is a 48-year-old female or something like 40-something. And I targeted minus 0.7 to minus 0.9 target refraction, and I implanted an enhanced monofocal eye-enhance. So this is her 2-week visual acuity 2020, and this is the autoref. We targeted correctly, and we got the spherical equivalent of 0. Now, in cases of PKP and DALK, what to consider when planning for the cataract surgery? Usually, unless it's essential, I go for the sequential approach because doing combined surgery of cataract as well as a graft at the same time will never give accurate results. It will give an approximate result with possible high refractive error, whether myopia, hyperopia, and mostly or definitely we will have some kind of astigmatism that can be high. I would keep the combined cataract surgery with the graft, usually for elderly people with bilateral poor vision and with already established cataract, to give them at least one eye to see properly with until we can manage the other eye. Now, so the order of the treatment is cornea first, and then do the lens second. Please don't reverse the order. I always say save your IOL until the end. Consider the IOL as the joker in the card game. Once you play it, you finish the game, you win the game, but you lock the system. So use it at the end of your game. You can cover all your gaps with the IOL and will make you win the game. So my sequential approach is usually we do the PKP or the DALK. 1 year later, we remove the sutures, and 3 months post removing the suture, aiming for stability of refraction and corneal stability, we start doing pre-op investigations to decide what we do. Now, 3 months post-removing of the suture, as we said, aiming for refractive stability, I assess the corneal astigmatism. So the corneal astigmatism can be less, or I divide it into 3 categories. If it's less than 6 diopters, between 6 and 12 diopters, or more than 12 diopters. If it's less than 6 diopters, if it's minimal, I will go for possibly non-toric lenses. But if it is a little bit more, I'm going for toric IOLs, toric EDOF lenses, or toric monofocal plus or enhanced monofocal lenses. If we're talking about astigmatism between 6 and 12, I will target the customized toric lenses. And if we are talking about more than 12 diopters of astigmatism, then I will go for arcuate keratotomies, the relaxing incision assisted by femtolasic to decrease the astigmatism to a level where I can implant a toric lens after that. So we should see just how we can use the femtosecond laser assisted keratotomies. You can see in the first video to the left that I do have high astigmatism for this patient. I already put the marks, and I put the marks where I want to do my arcuate incisions inside the graft. You can see the graft at the borders. After that, I manually open these with a blunt instrument or a blunt chopper to make sure to get the effect out of this relaxing incision. Now, this has a magnificent effect if you know exactly how to do it. For example, this is a patient who presented to me with 14 diopters of astigmatism where there is no IOL that can cover 14 diopters on the corneal surface. And this patient, if you look at the autoref, here you can find that he had like -12 on autoref, -12 on the corneal surface. We did that. 2 days later, he had like approximately, we're talking about -3 on the autoref, -4, with 3 on the corneal surface on the autocase. But if we go also for the comparative topography, we can see that the upper picture was done before the procedure with 12.5 almost astigmatism. After the relaxing incision, it went down to, as you can see, 1.75 with 10 diopters difference between both topographies within few days. So in such case, I'm sorry, I'm going, no, let's go back here. Yeah, so for example, this patient was planned to do cataract surgery after we decreased the astigmatism, but he was so happy with his vision going down to 1.75 corneal astigmatism. He avoided many of the symptoms he was having, and he was like, I'm fine here, let's not proceed. So let me just give some examples how we can use the new premium toric lenses in keratoplasty patients. This is a 51-year-old patient who did bilateral penetrating keratoplasty in 2005 and 2018. Her uncorrected visual acuity was 0.1, 0.2 with mild lens changes. She was told she needs cataract surgery, but no one was willing to do that for her. And she came to me, by the way, she's from Iraq. Her vision is 0.1. As you can see, the subjective refraction in the right is like +4, -6 in the left with pure cylinder -6. She was achieving 0.8 to 0.6. You can see the autoref on the other side. Now, I did the investigations. You can see regular astigmatism in the right and the left eye, which is matching the biometry over there. The endothelial cell count was in the right around 1,000, in the left around 1,100. So what I did for her is I did customized toric lenses. And this is her uncorrected visual acuity. In the right, 0.9, in the left, 6.6, unaided. You can look at the autorefraction for this patient. It was 0 spherical equivalent in the right and almost -0.5 in the left. The point here I wanted to show by putting the specular, this is the pre-op and the post-op specular microscopy, is in the right it was around 1,000. The cell count, almost same shape, just 900 in the right. If you look at the left, it was 1,140, it was 1,130. So the message here, we did not affect the endothelium by protecting properly the endothelial cell count in such a patient and doing it at an early stage. Another example of a 46-year-old female with a history of high myopia, advanced keratoconus, and history of bilateral contact lens related infections. She had penetrating keratoplasty 2024 And 1 year later, removal of sutures. 3 months later, we did the investigations as my protocol. And then I implanted a customized toric Zeiss lens because I wanted to go for very low power. You will see it now. And I implanted plus 1.5 diopter spherical equivalent minus a sphere lens with a 9 diopter of cylinder. You can see the author of this is the picture of her right eye with some scars. The left was already transplanted with removed sutures being removed. You look at the author if it's minus 13 with minus 11, and on the subjective refraction given minus 13 and a half with 6 cylinders of astigmatism, she could achieve 0.63, which is 6/9. Now, we did here the cataract surgery, and these are the investigations. It's aligning the good, the endothelium has good count. The OCT was good, given the patient is highly myopic because the axial length is about 30.2. So we did that, but the post-op results were not according to our expectation. There is an IOL rotation, and the axis of the IOL was, instead of being 156, it was around 110. So instead of going immediately and rotating the IOL, I waited for 2 weeks. Waiting for 2 weeks was for a reason. This eye is super big, the bag is super large, the Zeiss lens was barely fitting in the capsule. So what I did, I waited for 2 weeks, let all the healing go away if there's any remnants, which is going to go in 48 hours. And then let's allow for some adhesions in the capsular bag. So I gave 2 weeks. I went in. I just tucked the lens with the IA probe only, put it on the right axis, and lift. And next day, she is 20/20 vision with this axial length. You can see the auto-refraction. That was like hot from the oven just 2 days before I came here to the conference. She is 0/0 spherical equivalent with a 20/20 vision, and that's the real picture of the patient's cornea just 2 days ago. If you look at the specular microscopy, 1700 in the right, it is 1700 in the left, pre and post-op, which means we did not really affect the endothelial cell count. Don't wait too long before you do cataract surgery for keratoplasty patients. The earlier, the better, with low energy and with proper protection for the endothelium. Now, but just a point here, since we're talking about high axial length, please, whenever you are choosing an IOL for a low minus or a low plus, like a minus or a low plus up to 5 diopters, just be careful at what diopter the lens will change from biconvex to meniscus based on the manufacturer, so as to have your calculations just on target, because this will affect your result. Just a quick 2 examples about also patients with DALK, a 27-year-old who I did DALK in both eyes, in the right 2 years ago and the left a year ago, and she was planned for right femtolaser assisted arcuate keratotomies to decrease the astigmatism that you can see in the right eye, and the left was planned for removal of sutures. And then the right, we were planning to do either phakic IOLs or an phakic IOL ICL or an IOL, a toric one. So we did that. So we did arcuate keratotomies in the right eye. You can see where the incision site, and the video at the beginning was for this lady. Just 3 days ago I did it. And the left eye, we removed the sutures. And the refraction, or afterwards, was in the right, she was 0.5 with minus 2 cylinder, minus 2 sphere, minus 2 cylinder. She achieved 6.6, and unaided, she was 0.8. What to do next? Sometimes less is more. Just do nothing. You need to know when to stop. The patient is happy. Happy patient, 20 happy. It's not always 20/20. And also, this is an example of a DALK, a patient 40 years who I did DALK. She had more than 12 diopters of astigmatism. How should I manage? There's no lens that can correct more than 12 diopters on the corneal surface. I did arcuate keratotomies where you can see the incisions. I took the astigmatism down to less than 12, and then we implanted the lens, which was an enhanced monofocal toric lens, an enhanced toric, and you can see the results. You can achieve 0/0. So, just to give a few points what to consider when planning for cataract surgery in post-keratoplasty patients. Always check the corneal cylinder and axis in more than one device on the biometry, autocase, topography, and decide accordingly, and do your proper IOL calculations. Don't just depend on the companies to do that for you. Check the endothelial cell count and explain to the patient that you might need a DMEC in the future. This is why I go for hydrophobic lenses, because if needed in the future and I wanted the cornea decompensates, I want to do a DMEC, Hydrophobic lenses can hold the pressure of the SF6 gas better than the hydrophilic lenses. And do cataract surgery as early as possible with minimal phacopower and extensive protection to the endothelium. Coating the endothelium, this, as you saw in the pictures, could save your endothelium without really decreasing the endothelial cell count. So what are the kind of lenses in post-keratoplasty patients? We said hydrophobic are my way to go if they can correct the refractive error. Monofocal, enhanced monofocals, EDOFs, and toric IOLs, all can be, as well as ICL, used in post-keratoplasty patients. Trifocal is of limited use. In such cases, you can use with extreme caution and with expertise, just with DMIC. I wouldn't go for transplanted PKP patients. So the take-home message. It is great to do a PKP and DALC or DMIC graft, but don't be so happy and so proud if it looks good. There are many, many more steps to go. Corneal grafting is a journey. It's not just a procedure. And the IOLs, especially the premium IOLs, mostly the torics, can help you correct most of the refractive errors post-graft and complete your journey. So 20/20 vision can be achieved in post-grafted patients with premium IOLs, and even grafted patients have the right to dream of 20/20 vision. Thank you, everyone.